Today we'll be discussing family medicine, private clinics, and for-profit healthcare, as well as Saturday morning cartoons, with our special guest, Dr. Danyaal Raza. This is Doctor versus Comedian. I'm Dr. Asif, and this is the Doctor of Laughs.
Not a real doctor.
Ali Hassan. Now, normally, every episode I pick a topic for Ali from comedy and entertainment, and I question him about it. Then Ali picks a topic from medicine and health and grills me on that topic. But today is a very special episode. Today we'll be discussing family medicine, private clinics, and for-profit healthcare with Dr. Danyaal Raza. Now, there's no entertainment topic this week, but we're going to draw the parallel between private clinics and data brokering and the Saturday morning cartoons that we loved as a kid, right, Ali? I know you love them.
I love them. My mother would call me up. Come up now, she would say. I would say no. I'm very busy. I don't know why I'm talking like that. So let me introduce our guest. Dr. Danyaal Raza is a family doctor and the primary care and health policy scholar at what we affectionately call St. Mike's here in Toronto. It's St. Michael's Hospital. He works in the Department of Family and Community Medicine. He was named to the Medical Post's Power List as an influential physician voice in Canadian health policy. He's done a ton of writing, research, and media commentary that focuses on health system reform, and his analysis has been featured in the Toronto Star, the Globe and Mail, Washington Post, The Guardian, CBC, and CTV, just to name a few places. Dr. Danyaal Raza, welcome to the show.
Thanks for having me, guys.
So, Danyaal, we recently read an article that you wrote in the Toronto Star about the dangers of the privatization of healthcare. So we do want to get to that in a minute, but just to get everyone up to speed, you know, we have lots of international listeners from the US and elsewhere. So can you discuss very basically, I know it's a complicated question, but how healthcare is structured and funded in Canada, and then how that compares to, say, other countries?
Yeah, no problem. So I'll start high level and then we can go in whatever direction we want to take it. But I'll start by saying we actually don't have a single healthcare system in Canada. We actually have 13, right? One in every province and territory here. And that's because really the way we do healthcare is it's a partnership. It's a partnership between our federal government and our provincial and territorial governments. And it's essentially run at that provincial and territorial level. It's why, and this is for the Canadians who are listening, it's why in Ontario, your health card is an OHIP card, but in Quebec, it's a RAMQ card. And in BC, it's an MSP card. So that's why we have all these different health cards across the country. But I said it was a partnership because the thing that ties everything together, to the extent that things are tied together, is the federal government and the Canada Health Act, which is like probably, I don't know, the best piece of federal legislation, which is such a random thing to say in Canada. Mm-hmm. And it's an agreement. It's basically like an agreement for money that says the federal government will give your province or territory pretty substantial, chunk of cash and chunk of funding, as long as you do, the 5 things that are in the Canada Health Act. And among those 5 things are also the things that define our universal healthcare system, what it is and also what it isn't.
Just to get a little further into the weeds too, there's a situation, I'm in New Brunswick right now. If I break a tooth, which is something I felt might happen twice this week, or some such thing, some kind of injury, how does that work then? I'm an Ontario resident. I'm in a different province. I need healthcare in a different province. Where does that land up in what you're talking about?
I love it. This is like we're in class and I'm lecturing and I've planted questions.
Yeah, I go back to school.
Yeah, man. So there's a condition called portability. That's one of the 5 conditions in the Canada Health Act, and it basically says that, if you're an Ontario resident and you're somewhere else in the province or in the country, or you're a BC resident, you're in Manitoba, whatever, you can take your health card to the emergency department or the hospital in that province that you're in, even if you're even if it's not your own, to get emergency care. So if you chip a tooth and it can be dealt with in the emerge, or you break an arm or you have a heart attack, you can take your Ontario health card to that New Brunswick hospital, to that New Brunswick emergency department, and they'll deliver you care. And all the way the money flows and all that happens in the background, but you get the care you need uh, at the same level as locals would without having to pay.
So, how does the Canadian system compare to, say, the US or the UK?
Yeah, I mean, another great question. So maybe what I'll start by talking about what the system isn't.
Right.
So a lot of times when people talk about healthcare in Canada, they describe it as a socialized healthcare system. That's actually not what we have. A socialized healthcare system is one in which the system is both predominantly funded publicly, but also the public or the government actually owns most parts of the healthcare system. That's not how it works here, though. I'm a family doctor, but I work at a hospital. Um, and my hospital is private, but it's a private not-for-profit
Mm.
institution. Yes, it happens to get most of its funding from the government, but it's private and not-for-profit. It's got its own board of directors. They kind of run their own show. Similarly, as a family doctor, I'm part of a partnership group, and we run our clinic as part of the hospital. We're kind of independent contractors, but we're not government employees, even though most of our funding uh, is from the public, from the government. So this is like, to get technical, it's called national health insurance. Socialized healthcare is what the UK has, right? Their
Hmm.
national health service, where it's predominantly publicly funded, but also everyone who works there, doctors, nurses, social workers, they're actually employees of the government, and hospitals are also owned and run by the government. So that's like one difference. And then, no, the US is like the exception to every rule in healthcare, but
Mm.
probably, in life. And they have a system all into themselves that's unique amongst kind of all high income countries in terms of, the incredibly high, both private but also public spending, and really poor outcomes. But the other thing I'll say too about how Canada compares to other countries is in terms of how we spend money. So every dollar that's spent in healthcare in Canada, about 70 cents or 70% of that is public, and 30 cents or 30% of that is private. But what does that mean, right? I'm just throwing out
Yeah.
numbers without context. When you compare it to our European peers, so the UK I talked about, but also places like Germany, France, the Netherlands, they actually spend more publicly than we do. 80% or more of all healthcare spending in those countries is public, which I think a lot of people are surprised to hear, because the narrative in Canada is like public spending
Hmm.
is somehow out of control or unsustainable. But actually, you know, if you look at the stats, other countries like us spend more on their public healthcare system than we do.
But did they have better healthcare outcomes as a result of that in general? The countries that spend more of their own money, like as in public money?
Yeah. So, um, one thing so yes, and one of the
Hmm.
other things that's different is we define our universal healthcare system as only two things, right? Everything that happens in hospitals and doctor care.
Hmm.
But, if you need to see a dentist, if you need to get your drugs covered outside of hospital, if you need physio, if you need to see a psychologist, basically for that, we essentially have a US style healthcare system in Canada where, hopefully there's a public plan that covers you, for example, for drugs if you're old enough, young enough, or poor enough. If you live in the right city, maybe you'll have
Hmm.
access to publicly funded dental care. We're the only country in the world with a universal healthcare system that doesn't have universal drug plan. So we have tons of holes,
Hmm.
right? These other countries, they fund way more in terms of universal healthcare besides doctors and hospitals. So it means people can access them much more easily and their health outcomes are better. And then the last thing I'll say, the flip side to this is in all of these other countries, they also have more robust social care systems, right?
Hmm.
So housing is more affordable, um, education, especially daycare and post-secondary education is more affordable. So they have better health outcomes too because they do a better job on these social and economic
Hmm.
determinants of health
Yeah,
too.
minimum
So it's not
wage.
just the healthcare system alone, but it's like all of these things
Yeah.
taken together that lead to those outcomes.
So we'll transition a bit to privatization of healthcare in Canada, but maybe we should just set the stage. Like, I think a lot of people think, oh, America is private healthcare and Canada is public healthcare. But you just explained that that's not actually the way it works. That kind of dichotomy is not true. So what is, like, you mentioned some things that are private, but can you go see a doctor privately here? Is there privatization of healthcare, and what's the trend that we've seen in terms of that for and we'll just keep it with physicians, like that kind of medical care.
Yeah. So historically, in Canada, if you've needed to see a doctor for something that is considered medically necessary, all you need is your health card, right? And that'll get you the care that you need, whether it's in hospital or whether it's like out in the community, for example, through your family doctor. And that's really different in the U.S. for physician-based, care. You have to, if you're, poor enough or old enough, you can qualify for their Medicaid or Medicare system. If you have private insurance, hopefully it's good enough, etc. The reason why I said historically this is the case in Canada is because one of the things that's happening in family medicine, and I know we're going to talk about this later as well, is that um, family doctors are beginning to become more and more burnt out because delivering family medicine is becoming more complicated. There's also an increasing shortage of care in family medicine and primary care, and so it's creating pressures at all sorts of parts of the system at the same time where things are changing really quickly. So we're seeing these, virtual walk-in clinics that are practicing in ways that, regulators and legislators haven't caught up, and they're taking advantage of these, loopholes in the way we do our healthcare to charge patients out of pocket for care that you wouldn't otherwise expect to be charged for, like really basic healthcare. And you're even getting these new so-called executive health clinics that are also doing kind of funny things in terms of how they charge patients. And people are sometimes more willing to pay because they're so desperate, but also because they have the money.
Hmm.
And doctors who are, you know, not all doctors who are burnt out are doing this because I work with lots of great people who are committed to serving patients no matter how much money they have. But some doctors are looking for, an easy out, a better
Hmm.
lifestyle, and they're happy to see healthier, wealthier patients who keep them less busy.
Okay. It's interesting. I always like to draw parallels to for the layperson, not for me because I understand everything, obviously. But when I think about uh, healthcare, I like to say, U.S. private, Canada public is kind of like, red wine with red meat and then white wine with fish. Yes, we used to believe this, but now we know more, and it's not as simple as that. In the article that Asif mentioned in the Toronto Star, you have this great parallel. So you're basically talking my language in a sense by bringing up Saturday morning cartoons. You're talking about private for-profit healthcare. You're talking about data brokers, and you also draw these parallels with cartoons. A lot of stuff to dive in there, but let's begin with the most important question. Who is your favorite Transformer and why?
All right, this is a deep cut. This is a deep cut for the Transformers fans out there. Rodimus Prime.
Oh yes. Why?
Rodimus.
Yeah?
I know who Rodimus Prime is, but why don't you give us two or three lines about Rodimus? It's a very interesting story, Ellie. If you don't know the
I
story of
don't.
Rodimus Prime, give us two or three
Okay.
lines. Do you remember?
I love it. I
Yeah,
love that we're doing this. So there was a Transformers cartoon from I can't remember if it was the early 80s or
yeah.
the
I think around
or late
84,
80s or the early
85. Yeah,
90s.
yeah.
Yeah, yeah. And basically, Optimus Prime, who's the leader of the Autobots, just gets absolutely destroyed. And there's a succession of leaders that, gradually just they get things don't work out for them one way
Yeah.
or the other. And then this this leader emerges, who becomes Rodimus Prime, and there's
Yes.
this thing called the Prime Matrix, which is like a
Yes.
sign of leadership for robots.
Yeah. And he
Yeah,
gets
and
it
so it's like
inserted.
a
Yeah. And he
yeah.
started off, Ali, this is like, I'm such a nerd. So this was the movie, the Transformers movie. We'll talk about like these TV shows in a second. It was actually the final screen appearance of Orson Welles. He plays a giant robot that's going to kind of take over the world. So his voice acting, and then he passed away right afterwards, which is quite a legacy for, the famed Orson Welles. And so Hot
Mm.
Rod was he was a hot rod. He was like a car, is like really cool and kind of like, like a rebel. But then he had to take on the mantle of responsibility with the death of Optimus Prime. Now, later on, Optimus Prime comes back to life and, these other things happen. But
Don't spoil it.
so sorry. So anyway, yes, wow, that's really good. And so wow, this is such a diversion, but I do think we have to talk about this because it is actually relevant to what you're saying. And I didn't realize this in the 80s there was lots of these cartoons that Danielle was talking about. So Transformers, Ellie is one of the main ones, but GI Joe was another. I thought as a kid, oh, I like these cartoons on TV, and they made toys. So great, I'm going to buy the toy that's based on the cartoon because that's what Star Wars was, right? Star Wars was created by George Lucas, and then of course George Lucas actually made most of his money after the first Star Wars from his toys and licensing deals with Kenner and other companies. But that's not what happened, right? Like these were, and it's been
When Transformers said more than meets the eye, this is what they were
this is
talking
right.
about.
And so
This is what they were
these
talking.
cartoons were actually the whole purpose of their design. This has been well described in many documentaries. You can find the toys that made us was a documentary on Netflix, and
Sure.
we'll talk about this where the whole purpose of these was to sell toys, right? That's
Yeah, He-Man, Hot Wheels, yeah, I think you said GI Joe, Care
Care
Bears.
Bears, yeah.
Care Bears started out as plush dolls, and then people started watching the cartoons after the fact, not realizing that they're watching a glorified ad, effectively.
Yeah, and some of these shows aimed at boys, but as you said, some of them aimed at girls. She-Ra, Rainbow Bright. There was even a Rubik's Cube cartoon. Do you guys remember
Wait,
this?
Rainbow Bright was for girls? Just
Listen,
kidding.
man, we're
Yes.
but there was a Rubik's. Yeah, I watch way too much cartoons. So when as Ollie said, when you had this analogy, you really were speaking our language.
Yeah, yeah. This is the reason you are here today. You will come back, Danielle, but you always have to have great analogies.
That's right. That's
That's what
right.
we
That's
require
right.
of you. But let's get
Yeah.
into why this analogy was perfect for this world that we are now seeing in our Canadian for-profit healthcare scene.
Yeah. So I'm going to answer that question, but I'm going to do a little bit of very quick background first. And the reason being is, we've talked a little bit about private healthcare, but private healthcare can actually mean two things, right? It can be how you pay for care. So you can pay for care, out of pocket or through private insurance, and that's like private payment or private financing, or you can have public funding, which is essentially government funding, right? So that's kind of like the financing of healthcare and how it breaks down in terms of, these terms, private and public. But then the other piece of it is the delivery of healthcare, right? So wherever the money comes from, whether it's public or private, it comes to like a clinic or a hospital or whatever. And that clinic or hospital can be operated on a for-profit or not-for-profit basis. So, for example, I mentioned how, the hospital I work at, it's private, but it's a private not-for-profit hospital. In fact, all hospitals in Ontario are like this. In long-term care, you can have all sorts of different types of nursing homes, right? You can have private for-profit ones, and we saw that in COVID, especially the difference between private for-profit nursing homes versus, private not-for-profit, even publicly run nursing homes that were run by municipalities. The reason I bring that up is because what we're seeing now is publicly funded but private for-profit primary care or family medicine clinics, which really we haven't seen before in Canada. The way it historically worked is a bunch of doctors would get together, they would form a practice, and they would almost be like small business owners, right? So they'd build a government, they'd pay their rent, they'd pay their staff, and whatever was left over, they'd take home as income. But now there are these big companies that are getting into the game of primary care. And it's a bit puzzling too, because you can't really make a ton of money from doing bread and butter family medicine. So many of us are wondering, okay, well, what is the business model? Why are these companies interested in doing primary care? And so I'm part of this research team called the Health Tech and Society Lab that we're based at Women's College Hospital in Toronto, and I'm working with my colleague who's an amazing researcher. Her name's Cheryl Spithoff, and we basically were trying to figure out like what's happening here, especially from a technological angle, because technology is enabling a lot of these expansions, which is generally is good. We like technology. Technology is making my life easier as a family doctor, and it's making the lives of many patients easier too. But we also want to know what's the flip side. And so what we found is that there's these companies called data brokers, and they exist for everything, including for healthcare. Basically, they buy and sell data. And they've historically done this where they've bought data from all sorts of different healthcare organizations, and then they sold it to third parties, usually the pharmaceutical companies, but also researchers and governments, so that they can do their own analysis on it, and the data is anonymized and protected, and all that good stuff happens.
I think that's an important point because the layperson will hear something about a data breach,
Yeah.
and you immediately start to think, and sometimes you're right, that your very personal information, name, and everything that attaches to your name is out there. This is not quite that. You just referred to it as anonymized, right? Can you
Yeah.
just explain what this data looks like?
Yeah, so how it's being done traditionally is because we want this data for all sorts of reasons, right? Like especially researchers who are trying to understand, okay, where in the community is there more diabetes, or where are we over under prescribing medication? We want to know this information so we can make healthcare better. And what we do is we work with these large data sets that include information about, conditions and prescriptions, but they don't include patients' names, patients' phone numbers, patients' addresses, all of these things that would link health conditions to individual people, because that's not what we're interested in. That's none of our business. That's your business as the patient, and it doesn't help answer our questions around how can we, understand how healthcare works at a population level. So that's traditionally been the case. And, pharmaceutical companies want this information too because, for marketing purposes, drug development purposes, etc. But, but there's a but. Of course, you felt a but coming. So one of the things that we found was that these data brokers are actually buying up chains of for-profit primary care clinics, and they're doing that not because they're passionate or interested in delivering healthcare, but because they realize that there's a lot more money that they can make from directly controlling the data, right? So they're not just collecting the data and anonymizing it and selling it to third parties, but now they can use that data to develop custom and bespoke tools for their clients. Uh, One of the way that this is commonly,
And their
yeah,
clients are pharmaceutical companies. Is that correct?
there are clients from across the
They have
spectrum, so it includes
many different clients.
researchers and
Got it.
governments, but the majority are pharmaceutical companies, and that's kind of where we see some of the problems too, or potential problems, because what's happening is these data brokers are basically developing these algorithms that can be sent back into the clinics and the electronic medical records to identify specific conditions that patients have, which is not a bad thing. We would love to have help to do that, but then matching those conditions to medications that their clients from the pharmaceutical industry are prescribing. Now, on face value, that actually sounds like a win-win, right? If we're helping doctors diagnose patients and we're matching them to the drugs that they need, well, then the profit motives of the pharmaceutical companies and patients' interests align. So why not do that? The problem is that in practice, that's not always historically how it's worked, right? We have probably the best known example is the opioid crisis, where doctors were told one
Right.
thing about a medication, but of course, it's unleashed this like torrent of misery um, as a result. And there's also lots of research that shows that when, drug sales reps do these old school visits to doctors' offices to give them, so-called educational visits, or when they sponsor medical conferences, a doctor's prescribing habits actually deviate from best practices. So they're not prescribing as evidence-based as they would otherwise, and they are and the prescriptions that they are writing are also a lot more expensive. So I think this is why we need to be pretty cautious about some of these things that are happening.
So yeah, and the analogy I guess with the Saturday morning cartoons is we didn't realize that we're the product, right? Like,
Right.
we didn't realize that was the goal. So let me ask you a slightly different question of for profit. Let's say a hypothetical person's like, yeah, but you know what? I don't that's fine. I'll take this danger of the data brokers, and I'll
Hmm.
accept that. But then what do you say to people who are like, yeah, but they just say to me, Asif, like there is a uh crisis in family medicine
Yeah.
right now, and what is the solution? Why don't we just do for profit? Because if I can pay for it, right? So I'm paying to
Yeah.
go to a concierge clinic or whatever. So I'm going to pay for that. And that way it frees up the rest of the system for everybody else. What's wrong with that? What's wrong with that? So how do you respond to that?
Great question. So two things. One is it's not good enough for us to say no to everything. We have to be able to say yes, right, to things that actually make things better. And I want to talk more about about the yeses because that's so important. I'm really excited about how we can make things better. But first I'm going to answer that particular question because it is something that that you hear a lot, this so-called pressure relief valve. Okay, and I'm going to tell a story. So I want you to picture the last time you went to a grocery store and it was just bananas. Everyone is trying to, do their 5 p.m. shopping, get home, make dinner for their families. All the cash registers are open. Everyone is lining up. Now, imagine that the store manager came on the intercom and said, ladies and gentlemen, we're changing our store policy, and now half of the cash registers are reserved only for the people who can pay twice as much for the same groceries that everyone else is buying. Okay. So now all of a sudden, maybe the richest, I don't know, 5%, 1%, 10% of the people in the grocery
Mm-hmm.
store, they're going to go to those half of those cash registers and they're going to just fly through those lines. But then the 90, 95% of everyone else who just want to buy groceries and get home to their family and get on with their lives, well, they're stuck with half as many staff to help them. Their lines are going to get, twice as long, if not worse. People are going to get frustrated with the level of service, uh, and they're not going to want to go grocery shopping again. So this is essentially what it's an oversimplification, but this is the problems that we see when we introduce, a parallel system of private healthcare. We don't have an unlimited supply of doctors and hospitals. So instead of a pressure relief valve, it's actually a siphon. You're taking resources away from the vast majority of folks who just want to get care when they're in pain, and you're reserving it for people who can jump the queue. Why? Because they have more in their bank balance than you do.
When we talk about the crisis, Asif and I have spoken about this. We read about the crisis in family medicine. Is that what we're talking about? Or is that at the root of it?
Yeah, I mean,
That's
unfortunately,
too loaded a question, I'm
no, it's
sure,
not
to
loaded a
answer.
question. I mean, unfortunately, we're talking about a lot of things. Like these are
Mm.
not new problems. They've kind of been bubbling along for a while, and we haven't really had we really haven't had leadership, in particular political leadership, that's really taken it by its horns. So actually, we're seeing this in lots of different ways. One is the fact that there's 6.5 million people in Canada that don't have access to a family doctor or primary care. Another one is that not for emergency care or cancer care, but for elective care, things like hip and knee surgeries or cataract surgeries, people are waiting much longer than they should. Um, yeah, and actually, we're also seeing it and we've been seeing it for a long time for things where universal healthcare was never available, right? Like prescription drugs. There are like 1 million people in this country who are cutting down on their heating bills or skipping food purchases so that they can pay for their prescription drugs. There are people who need home care who can't get it because they can't afford it or because there's just not enough public funding for it. So we've seen it forever for things that are outside of our universal healthcare system, but we're also starting to see it in these parts of our universal healthcare system too. And the question is, what do we do about it, right? I don't think anyone who
Mhm.
believes in Medicare and universal healthcare system is going to talk and defend the status quo. I mean, that's totally ridiculous. I think the question is what are we actually going to do to make things better?
Yeah, and so what do you think? I mean, it's a huge question to ask, but what are some of the solutions to the crisis? Because we've seen some things that are not going over that well, and we're talking about governments penalizing family doctors, and we're seeing it in Quebec. And then you probably know about this, Danielle. In PEI, they want every full-time family physician to have a certain number in their roster and see 24 patients a day, like they must see, so I don't know. That seems like that's maybe not the best idea to like, use a stick to these people.
Mhm.
So, but what are the solutions, right? Like that clearly seems like a bad idea, but what are the options here?
I love talking about this because there's actually some good news. Okay, there's two really good pieces of news. Number one is there are a lot of countries that are actually doing what we need to do. So we don't need to reinvent the wheel for the vast majority of these problems. We just need to make adapt them to our Canadian context. And then number two, even within Canada, we're actually doing a lot of what we need to do, but we need to do more of it. So let's start in family medicine and primary care because that's where I spend most of my time. But we can talk about other things, including, you know, surgical wait times, emergency wait times, those things as well. Right now, most family doctors run their practices as small businesses. At the same time, family medicine is way more complicated now than when Medicare came to be in the 70s, right? In the 60s and 70s, when people got sick, it was like with heart attacks and broken bones, and most healthcare was delivered in hospitals. But now, chronic disease is such a bigger part of everyone's lives. Things like diabetes, hypertension, cancers, asthma, COPD. And this care is being delivered more and more by family doctors. And so we're having to hold way more in our heads than we used to. And it means we actually have less time. And frankly, new grads and mid-career folks like me, we don't want to also be small business owners. We don't want to also have to, worry about payroll and HR and rent and paying for the utilities. We just want to be doctors. And the combination of these things is what's leading to a lot of burnout and us losing folks in family medicine. There are other countries who are not struggling with this in the same way that we are. They have their own problems, but they're much more manageable. And the reason they're doing that is because team-based care, right, where it's not just a doctor and a nurse and a secretary, that's the norm, not the exception, where when you go to see your family doctor, there's also a social worker there if you need to see them, or a dietitian, or an in-house pharmacist, physiotherapist, whatever is unique to that particular community. So you're not just relying on one person for your chronic disease management. And the other thing that they do is they think about their primary care system like we think about our education system, our public education system. So, for example, like we were talking, before we started recording about our families, and I have two kids who are in school. When I signed them up for their school, I just went online. I put in our address. I saw what was the local public school, and I signed them up. And if I move to Cornwall or Sudbury, or if I move to Windsor, I know just like there was a neighborhood school where I live in Toronto, there'll be a neighborhood school that I can depend on that will be probably like a 15, 20-minute commute from where I live. So we need to start thinking about primary care and family medicine in the same neighborhood way we talk about or we think about public education. Because how it works right now is you graduate, right? And then you set up practice wherever you want, and you have to run it as a small business. Hopefully you find five of your buddies and you guys, you set up a group practice, and you don't know if that community doesn't have enough doctors or have too many. You're just kind of left to your own to do it. We don't ask that of teachers, right? When teachers finish teachers college, we don't say, hey, find five of your friends, set up a school, and we'll pay you for every student that you teach. That sounds
Yeah,
totally
exactly.
bananas,
Yeah.
right? But that's how we're dealing with primary care and family medicine. But that's not the norm in countries that do it better than we do.
What about other solutions? So team-based care, that's one thing. And so, but what about other solutions? So what are your thoughts on like nurse practitioners? I know lots of governments want to fund nurse practitioners as a possible solution. Would they be part of these teams? Is that independent? Is that a good idea, bad idea?
Yeah. There's lots of work to go around. And for as long as I've been a family doctor, I've actually worked with nurse practitioners in all sorts of settings. So I think, yeah, nurse practitioners, along with other folks like physician assistants, have a role in taking care of more people. I think as we expand the different types of people who are involved in healthcare, which is something that we need to do, we also need to make sure that we don't treat everyone as a completely interchangeable part because family doctors are different than nurse practitioners, are different than physician's assistants, and we all have our unique roles and areas of expertise. So I think like as we think this through and as we think about how to build teams and how to match them to community needs, we have to take a surgical approach, so to speak. We need to use a scalpel in thinking about this and not a hammer.
And then what about, because I think some people might say, to one of your potential solutions, the team-based care, they're like, that's great, but as you said, there's the supply. As you said, there's lots of work to go around. So how do we address the supply? And this is something I don't know, Ali, how much you might know about this, but we know that over time there's maybe a decreasing interest in family medicine for various reasons, which we can talk about in medical schools and people pursuing residency. And there's more recent studies that have just come out where even people who've pursued family medicine aren't doing a traditional kind of practice like Danielle does. So they're, I don't know, doing locums. They're working, they're going to some place for like a couple of weeks, then leaving. They're working in walk-in clinics. They're not doing a traditional family medicine role that we're used to, right? They have a roster of patients. So, what are the solutions to this workforce manpower issue?
If you build it, they will come. Uh, and the reason I say that is new grads don't have opportunities where they can easily walk into teams and just worry about being a good doctor and not having to be that small business owner. For example, in Ontario, um, 100% of people don't have access to a family doctor. Obviously, it's lower than that. That's why we have a crisis. But if you just think about team-based care for a second, only 20% of people in Ontario have access to family medicine or primary care through a team. The rest of the folks who have access, it's through this old school kind of solo practice model. And it also means that those are the most of the opportunities that new grads see before them. But we're training them and teaching them in teams because this is the modern way that you do healthcare, but we're not creating opportunities for them to step into those teams. So number one is if we actually build those teams for docs to step into, people will step into them. We'll see more family medicine graduates actually practice family medicine as opposed to doing things like working full time in the emergency department or doing other kind of non-family medicine things. So that's one solution. And the other one is, and I'm going to qualify this, is no matter what type of doctor you are very well paid. You are doing much better financially than your neighbor. Within medicine, there is a huge gradient between
Mm-hmm.
so-called cognitive specialists, so people who are psychiatrists, family doctors, pediatricians, and procedural specialists. So people who are high volume surgeons, sometimes making three or four times more than their relatively lower paid colleagues. And this influences when you're in medical school, the career that you
Mm-hmm.
decide to pursue. So part of it as well is like narrowing that differential to try and not squeeze people, but encourage more people to go into family medicine. So you got to work on making the practice environment more similar to what you need to actually feel good about the care that you're doing. And you need to kind of do some old school financial incentivization um, to encourage people to choose family medicine over, one of these very high paying specialties.
I haven't heard two things that I've been listening for, and I'm wondering what your thoughts are on that. Number one is uh, immigration related, increasing immigration to allow foreign doctors in. And then the other thing is something that's kind of a buzzword of sorts these days, which is virtual care. How do you see those two factoring into this family medicine crisis?
As bad as the things are in Canada, they are much worse in other parts of the world. And so I have very significant reservations with us going to lower income countries and essentially poaching their healthcare staff,
This is the
especially their
Manny
doctors.
Pacquiao model. Do you know who Manny Pacquiao is, Danielle?
The Filipino
The
boxer.
Filipino boxer.
Yeah.
When he would win bouts and win a lot of money, people in America would say, okay, can you donate money here? Can you donate here? We need money for this group and this group. And he would say, no, because in America, you have people who have money. In my country, it's so much more important that I take my money back to my country and help my people. So this
Okay.
is what I
It's
would refer to
the
as a virtual.
reverse problem, right? We're taking
Yeah,
a resource out of a country that needs it. We call it the brain drain, but it's not just an intellectual, it's not just the scientists moving over. It's actual people who should be seeing the patients, right?
sure,
Danielle?
Yeah.
sure.
And to get even
Okay.
more, a little bit more intense about it too, it's kind of like medical colonialism, frankly,
Mm-hmm.
right?
Mm-hmm.
Um, that being said, there are many people in Canada who are internationally trained physicians. People are already here who are doctors who are trained somewhere else and they're driving cabs.
Yeah,
I mean, we need to do
we've
better,
all met them.
right?
Yeah, 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 yeah,
So
yeah.
I think for folks who are already here, we need to create more opportunities and better pathways to get people qualified. I know, I think Nova Scotia actually has made this a big priority, and other places like Saskatchewan make it easier. So it's this balancing act where if people are here, then we need to do what we can to get them up to speed to practicing healthcare in Canada and give people opportunities. But we also don't want to, you know, we don't want to be medical colonialists at the same time.
Gotcha. And then virtual care. What are
Yeah.
your thoughts on that?
Okay, I have many thoughts, but I will give you only a few of them.
We want to hear all of them,
Yeah.
please.
No, I love virtual care as a tool as part of my practice. It means they're like before every visit was an in-person visit, even if it didn't need to be an in-person visit. But now there's so much I can do even over something as simple as a phone call, right? That's just become a normal part of how we deliver care. Of course, patients love it. They can take it on a break from work. You don't have to take a half day off. I love it because I can do way more, virtual visits in one chunk of time than I can in-person visits, so I get more done. I love it. But again, you felt a but coming. It's a tool, right? And like any tool, it's really important how we use it. And we don't want to use it to duplicate things that aren't going to make care better. We have walk-in clinics, across the country, and they exist because people don't have enough there aren't enough family doctors, right? But the way we fix the family doctor crisis is not by having more family doctors do walk-in care, but by having more family doctors do family medicine. The reason I bring that up for virtual care is because we're seeing more and more what are essentially virtual walk-in clinics come about where you don't know the person you're talking to. It's this, episodic care, and you don't even have the option for in-person care. And actually, when people have studied this, they found that when you compare these virtual encounters with encounters where it's also virtual, but you have the option to see the doctor in person, your care is worse. You're requiring more in-person visits, and the chance of you needing to go to the emergency department in the next month is actually higher. Not only that, but these virtual walking care clinics are happening because businesses are seeing a market opportunity. You don't have to pay for rent or a secretary, you just have to buy the software. It's your overhead is way lower, so you can make a lot more money. And because regulations haven't fully caught up with virtual medicine, it also means there's a lot more loopholes where you can charge patients out of pocket for things that they wouldn't have to pay for if they saw you in person. So I love virtual care. It's a tool. How we use it is really important. We need to use it in a way that actually gives people more access to family medicine in a way that also delivers high quality care. We shouldn't use it to duplicate the things that aren't working and that we don't want the future system to look like.
Amazing. I think, Danyaal, we'll leave it there. Sometimes, you know, we'll have a discussion that leaves more, um, that leads to more questions than answers. But I think you have a very healthy, your ratio is much more about answers and solutions
Yeah.
here. Are they going to be easy to come by is a whole other thing. But this is a really, really enlightening talk, and very happy we got to talk to you about it.
No problem. Can I just shout out a few groups that if like people are listening to this,
Hmm.
particularly if you're in Canada and you're like, whoa, this guy actually is giving me a little bit of a little sliver of hope that people should check out a few different groups if that's okay. One is,
Of course.
I've learned so much of what I've done because of this group called Canadian Doctors for Medicare that do, it's evidence-based, values-driven reforms for the healthcare system. So whether you're a doctor, whether you're a nurse, whether you're just someone who cares about your health and the
Hmm.
healthcare system, go check out Canadian Doctors for Medicare, type them into your favorite search engine. And the other organization I'm going to plug is actually this project called Our Care, and it's not my project. It's run by a colleague of mine, and they're doing some amazing work on understanding what do people want out of their own family medicine, their own primary care experience. There's a ton of stuff on there. They're interested in talking to people to get their perspectives. So go check out ourcare.ca as well. Those two groups, if you're looking for something to do after you listen to this.
Amazing. We'll have links to that on our website and on our in our show notes. Thanks, Danielle. Great talking to you. I'm sure we'll see you again on the show.
Thanks so much. So that's our episode for today. Let us know what you thought about our discussion with Dr. Danyaal Raza. I mean, there's so many other things we could have talked about family medicine. As he mentioned, we could also talk about emergency wait times, surgical wait times. There's many issues to talk about in Canada, so hopefully we'll get him back on at some point to talk about this. But let us know what you guys thought about this episode. Also, let us know, did we miss any of those shout outs to Saturday morning cartoons from when we were kids? I could probably do a whole 3-hour podcast on those ones, but let us know, drvcomedian@gmail.com, Dr. V Comedian on Twitter, Facebook, Instagram, Blue Sky. We're everywhere.
And if you'd like to get in touch with Dr. Raza, DanyaalRaza.com is his website. You can find out more about him. I think we just sort of grazed his his credits. He's got an incredible resume and does a lot of great work. So you can definitely feel free to reach out to him through his website.
Mm-hmm. Speaking of your website, what does your website say you got going on in July? Anything?
Not much, buddy. I'm chilling. I'm chilling. Last summer, I think I've mentioned this several times on the podcast. I did the hernia surgery. Okay? Only 2 years I waited for that. Not because of family medicine crises, but because of my own laziness.
Okay.
But yeah, so half the summer was just sitting around with a bag of frozen peas on my groin. So this summer I'm interested in enjoying myself, spending some time with my children while they still know who I am and recognize me and I recognize them. And yeah, I'm chilling in July.
Great. I mean, the weird part was the frozen peas was before he had the surgery, so that was
That's
strange.
weird.
But
Just prep. Just prep.
That's right. You got to practice for
Dress
3 months
rehearsal.
beforehand. Everyone knows
Everyone
that.
knows you got to do the dress right.
But what everyone also should know
Yes.
is that although myself and Dr. Raza are doctors, we're not your doctor. Medical issues we talk about are for your interest and information only, and they're not medical advice. Please consult your medical professionals for actual medical advice. Thanks for listening.
See you back here soon.